Welcome to the ninth live session in the Class 2 Clinic Season 3 series. Today's session focuses on revisiting key clinical application pearls on anterior segment evaluation and tonometry. And with us, we have Anindita Paul and Arpita Mandal, who will be guiding you through this session. And students, we encourage you to participate actively and please share your questions and so that we will be able to address them during the discussion. I will hand over to Anindita. Anindita, you can introduce Arpita and then start with your presentation.
So hi, I'm Anindita Pal. So Arpita is will be our panelist. She is the corneal consultant, and she's working in Car campus at LVPEI Institute. Okay, so she will also will be there to with us for this presentation.
Yeah.
For this nice big introduction of me.
Let's start.
Yes. Yes. Floor is yours.
Yeah. Thank you. Thanks. So first, I'll be starting the first case. To a 42 years old female came in our clinic with the complaint of pain associated with headache, which was lasted for past 2 weeks. And there was a history of present illness. The patient was seeing occasional halos also for the first 10 days. No previous ophthalmic consultation was taken previously. And coming to the systemic illness, there was nothing was noted in the history part. So first, I would like to highlight what are the key elements of a glaucoma history, because in the glaucoma, history taking plays an important role. So each and every point justified the glaucoma diagnosis and the treatment. So I'll take you through this history part first. So first, you should note down the ocular symptoms. If the patient is complaining about any pain and redness, you need to note down. You need to ask them what is the time period for that. Is it for 1 day or 1 week? What is the duration of the pain or any other ocular symptoms? And if the patient is complaining of itching sensation, that also can be a side effects of any other drugs. Any anti-glaucoma drug side effects also can be happened. So you need to note down each and every point and the duration of the symptoms. Okay. Next is previous ophthalmic consultation. So previous ophthalmic consultation, we can reveal many things from this previous ophthalmic consultation. If you get any previous report of any glaucoma patient, a few things you need to remember, right? The first thing is the baseline IOP. If you get the baseline IOP, you need to note down what is the baseline IOP. Next, if you get the Cubdix ratio, then you need to mention the Cubdix ratio. Central corneal thickness, if you get, then you need to note down that. Okay. So sometimes we get confused. There are many reports we get like which should be the baseline IOP. So the baseline IOP is the IOP from where the patient was suspected as glaucoma or the glaucoma treatment was started. So that should be the baseline IOP. It is not like that baseline IOP always should be high only. It can be low also. Okay. So anything can be there, but you need to mention the first IOP from where the glaucoma suspicious and suspect or the glaucoma treatment was started. That should be the baseline IOP. Okay. Next is the Cubdix ratio. So you should mention Cubdix ratio that I told. And if you get anything related to glaucoma, the fundus and HVF, Humphrey visual field report or the central corneal thickness report, you need to attach that. If you can elaborate the parameters of visual field report, then elaborate it in the history part. If not, then at least attach the report and just mention the date when the HVF report was done. Okay, so that's all for the previous ophthalmic consultation, or if you get any previous report. Okay, next, coming to the past medical history, few medications like anti-glaucoma medications are restricted for a few systemic conditions. Suppose like what to say? timolol and brimonidine. That's the anti-glaucoma medication which is restricted for cardiac patient or any pulmonary patient. That can negatively affect on them. Okay, so that's what. And in the past medical history, you need to ask about the steroid use also. If the patient is using steroid, then you need to mention the doses, how many times they are getting, because we all know that the glaucoma is all about IOP. So steroid can spike up your IOP, okay, intraocular pressure. So you need to mention that in the past medical history. So the next is the family history. So glaucoma, as we all know, the glaucoma is a multifactorial disease. So genetic also can be a factor, okay. So it helps to diagnose the low tension glaucoma better, the family history. So if patient has a positive family history, if you mention that in the report, although if we get the normal IV, we should perform gonioscopy for the patient. Okay, why it is like usually what we do, if we get a normal intraocular patient and normal like if the intrachamber depth is also normal, we skip gonioscopy, correct? But if the patient has positive family history, you need to do gonioscopy before dilatation, because after post dilatation, what happens? The reading will be variable or alter. Okay, so that's what the family history also important for glaucoma patient. Next is current topical medication. So if the patient is using any anti-glaucoma medication and or anything, many medicine, yeah, you need to record all the medicine. But for anti-glaucoma medicine, what is the special for them? You need to mention the last application time for the patient for anti-glaucoma medicine, because that anti-glaucoma medicine has a time like duration to effect. I mean the effective period. So if one drug can affect 12 hours and the other drug can affect 24 hours. So if we see that after using the drugs also the IOP is not under control, then what the consultant will think, maybe the drop is not working for the patient. But actually it is not the thing. Maybe the drop is working, but the last application time was 2 days before or 1 day before. So that's what it is the IOP is not controlled. So always you need to mention the last application time for the anti-glaucoma medication or anti-glaucoma drugs. Okay. Then the last part, the next part is allergic to medication. See, few anti-glaucoma medications are restricted for few allergies. If the patient has sulfur allergy, we cannot prescribe them carbonic anhydrase inhibitor like dorzolamide, brinzolamide type of drugs. We cannot prescribe them. So that part, that portion also you need to mention. And if the patient has any specific drug allergy, I mean in anti-glaucoma allergy, because many anti-glaucoma medication has allergic reaction. If any patient has allergic to any specific drug, we can skip that drug and we can go to the other anti-glaucoma medication drug. Okay, so that's what each and every point justify the history part. Like that's what the importance is glaucoma history in that's what the importance of glaucoma history having for the patient. So you need to take care of each and every point very carefully. Okay. Yeah. So from here we'll move to the case that yeah. So previously, as you have seen, the patient came in our clinic with a complaint of pain and headache. So now we will go to the slit lamp findings of the same patient. The patient, while doing slit lamp, the eyelid was flat. The conjunctiva shows congestion in the right eye, but the left eye finding was normal. Sclera was normal in both the eyes. Cornea was clear in both the eyes. So, but anterior chamber depth revealed right eye it was 1/4 CT, whereas left eye had half CT. Iris shows normal color and pattern in both the eyes, but the pupillary reaction in the right eye, it was round, regular, mid-dilated pupil, and the pupillary reaction, it was fixed. Okay, and the left eye, it was round, regular, and reacting. Next, we took IOP, so in intraocular pressure. So intraocular pressure, right eye was really raised. It was 26 millimeter of mercury. We took at the time at 11 a.m. morning, and the left eye shows left eye was 13 millimeter of mercury. Okay, so as the IOP was spiked up, so we perform gonioscopy. Always we know that if the IOP spiked up, we have to check the angle status. So what angles the gonioscopy revealed, the right eye had closed angle and the left eye had occludable angle. Yeah. So from here, I would like to move our first clinical part, which is related to the anterior chamber depth and what we usually do to our clinic, like how we check the anterior chamber depth. So yeah, so this is our first clinical part. It is on like, we actually use the binary technique in daily basis in our clinic. But while performing this technique, sometimes we may like some error can happen. Okay, so I just put the common mistakes which can happen during this technique. Okay, so in this pearl, you can see the first one. This first one is saying that if you put the incident angle. So now what is incident angle? Incident angle is the angle of observation and the angle of illumination, the distance between the angle of observation and the angle of illumination. Okay, so this two slate, the difference should be optimal. What is the optimal difference? It is 60 degrees. So if you deviate at least 10 degree also, it will give you a false impression of narrow angle. That means at least as the angle, although the angle is open, it will give a false impression of narrow angle. So this is the first mistake that can encounter during this technique. The second mistake can happen, that is that we in vanadic technique we use the cornea as an interface. Okay, we compare the peripheral anterior chamber depth with the corneal thickness. Okay, so if you put a very thick or very thin beam over the cornea, it will misinterpret as narrow angle or a open angle. If you put the thin beam, you will interpret as an open angle, although the angle is closed. And if you like put a very thin beam, a thick beam, then it will misinterpret as a very shallow ACD anterior chamber depth. So you always need to be careful while putting the slit beam over the cornea. Okay, so the third one, if you need to, as we are checking the peripheral anterior chamber depth, so always you need to focus, or you need to put the slit beam onto the limbal border. So apart from the limbal border, if you put the slit beam on centrally, then always it will give a thicker, deep anterior chamber compared to the peripheral anterior chamber. Okay, so always you need to put it at the limbal border. So these three mistakes we can encounter while doing this technique. Yes. So from here, I would request my panelists to take over and just explain the next part. Now over to you, Arpita.
So, thank you for clearly highlighting the essential components of glaucoma history and the jumper also.
Hello.
What happened? Arpita, are you there? Arpita, can you unmute? Not able to hear you.
Yeah. Okay. So
Yeah,
in this
yeah,
jumper,
you
we can
can,
see.
yeah, start from the beginning for this pearl.
Okay. So thank you for nicely explaining the first jumper and the essential key points in glaucoma history. So now I am going to explain the second example. So you can see the question is how to confirm biprism is in the contact with cornea while we do approximation tonometry. So here you can see the answer that the presence of leading light illumination at the limbus due to the total internal reflection indicates that biprism is in the contact with the cornea. So how it is happened? So when the prism touches the tear film on the cornea, the reflecting the total internal refraction creates a bright semicircular blue line at the limbus. So the rings tell you the biprism is contacting the cornea at the correct point, and you can now proceed to adjust the prism forward to obtain the semicircle. So now the question will be how total internal reflection happens. So when you bring the biprism close to the cornea with the cobalt blue light on, so you will get a two medium. So first one is prism, which is having higher index, refractive index, and second one is piercing or cornea, which is having lower refractive index. So the blue cobalt blue light shines into the biprism. Light inside the biprism hits the tear interface, prism and tear interface. So light gets reflected back. So it is completely bounced back, and reflected light appears as a bright ring. And then only you can get to know that the prism is in the perfect touch with the cornea. So that's all regarding our clinical pass. Now I would like to ask my panelist Anindita to take over and continue the case.
Yeah, thanks for the explanation, Arpita. So from here, I'll continue the case. Yeah. So next, after doing the gonio, the undilated fundoscopy was done. So obviously, as the IOP was raised and gonioscopy also shows occludable and closed angles, we didn't dilate the patient immediately after this test gonioscopy. So the doctor has shown that the fundoscopy was done, which shows the right eye cuptics ratio is very large. Cuptics ratio, it is 0.9, and the left eye showed 0.6 Cupdick's ratio. So then the patient was diagnosed with primary angle closure glaucoma. And as the gonioscopy shows close and occludable angles, so YAG-PI, I mean PI means YAG peripheral iridotomy was suggested or was advised for the patient. And as the Cupdick's ratio shows very large Cupdick's ratio, and glaucomatous cupping was seen. So the patient was started with anti-glaucoma medication. So that's all for this case. So now I would just briefly highlight like what are the learning objective for this case. So first, starting from the first one, like first slide. So you have seen like what how you can take the history for a specific glaucoma patient. I mentioned all the points, each point, like how we'll check the history technique, how you take the history one by one. And next, we learned that how you carefully take the anterior chamber depth. Like sometimes we do mistakes while checking the anterior chamber depth. Always you need to careful for the 2 to 3 things that I mentioned in the PPT and in that slide. And the next is was tonometry. So always you need to do probe adjustment. Otherwise, it will give a wrong measurement if you do not touch the cornea properly with the probe. So it will give a wrong measurements. Okay, so you need to check a tonometry properly. Then if you get high or raised IOP, you need to perform gonioscopy, and then the rest of the test will be done. Yeah, so that is the learning objective for this case. Now I would request Arpita, she will continue with the next case. Now over to you, Arpita again.
Would you change the slide? Just to
Okay.
am I audible?
Yeah, you are audible. Please continue.
Am I audible?
Yes, you are audible. You can continue with the case.
Okay, so now I'm going to present our second case that you can see a 30 years male patient came in our clinic with chief complaint of intermittent headache for past 6 months. While we took the present image or were asking about the spectacle, and he told that he started using spectacles since 2 years, and now currently whatever the present spectacle he is using, it's only 1 year old, and he doesn't have any such kind of ocular or head injury and no previous ophthalmic consultancy also. So moving to our next slide, when we did our refraction part, we got that the best corrected visual acuity was 2020 in both eyes, and the PGP he is using it's plus 0.75 depth of cylindry on the right eye, and left eye is only about +1. While we did subjective acceptance, the right eye got the same as well as the PGP plus 0.75, and left eye got some minimal cylinder power, it's minus 0.25 at 90-degree axis. And next, while we do our slit lamp examination, can you please, thank you. So while we do our slit lamp examination, we saw that the eyelid was flat in both eyes, conjunctiva sclera was normal in both eyes, cornea was also clear, and chamber depth was 1 cm in both eyes. Iris was also normal color and pattern in both eyes, and round regular reacting pupillary reaction we got in both eyes. While we did the IOP at morning time 9 a.m., we got 19 millimeter of mercury in both eyes, and then patient was dilated, and after some time we checked that Kapdix ratio, and we got zero 0.3 in right eye and zero 0.4 in left eye. So till now we can see that IOP was normal, anterior chamber depth was normal. After dilation, disc was healthy, fundus was okay. So everything appears normal and the case seems straightforward. But you can see that patient's primary chief complaint was only intermittent headache, even after using the perfect spectacle also. So till now, have we overlooked any crucial test that could change the entire diagnosis? So I would request my panelist Anindita to provide her perspective in this gap in our assessment if we overlooked or missed any crucial test. So it's over to you, Anindita.
Thank you. Thank you for the nice explanation. Yeah, so sure. So yes, just like Arpita said, IOP was normal, anterior chamber depth was normal, disc healthy, fundus okay. So are we really excluding any test? So yes. So if you see the IOP which was taken before, it was 19 millimeter of mercury. Okay. So it was, you can say it is a close to borderline IOP. Okay. So we thought to take, although we don't take the post-dilated IOP in the daily basis, but as it was 19 millimeter of mercury, I mean close to borderline IOP. So and the patient was complaining of intermittent headache also. So we took the post-dilated IOP, and it shows that the right eye was spiked up to 24 millimeter of mercury, and the left eye was 26 millimeter of mercury. So by this number, you can understand it is really raised. Okay, so now. After getting our high IOP in post-dilated case, so we really felt that we mistake, we failed something to do, like we failed gonioscopy, because gonioscopy should be done before dilatation. Otherwise, it can alter your measurement. I mean, the angles, structures, it can alter if when the people get dilated. Okay, so that's what we call for follow-up to the patient. So when the patient came for follow-up, the gonioscopy was done. So that time, this is the reading for both the eyes, which I put in this slide. The same reading was got, like the same reading got in for both the eyes. Okay, so if you can see, two types of gonioscopy perform, non-indentation and indentation. So the non-indentation gonioscopy was found up to till anterior trabecular meshwork. Okay, so we did then indentation gonioscopy, which was showed till scleral spur. So by this measurement, by this value, you can understand that it means the angles were occludable. In the previous session, already the gonioscopy measurement was told by our one of our panelists, but so you can relate to this fact that when it is showing in the non-indentation gonioscopy till ATM and till antetrabecular meshwork, and the indentation when after putting some sort of forces, the angle is opening, that means it means it's an occludable angle. So finally, for this patient, ERPI also was advised. So the ERPI was done for this patient. Yes. So from this case, some points to be, you need to note down some points. Like first one is angle closure can be a cause of intermittent headache. So first, any sort of intermittent headache, we always think of changing of the glasses or spectacle power change. Okay, or else migraine. Sometimes we think systemic illness of migraine, but we very rarely think that it can be related to the angle also. Okay, that like angle we really think later on. Okay, so but you need to know that angle closure can be also a cause of intermittent headache. Okay, and the second point is the anterior chamber depth doesn't always reflect the angle status. It only serves as a clue. That means, see, if you remember the anterior chamber depth which we put in the slide, that is also was 1 cm. Okay, so 1 cm means it is a normal anterior chamber depth. So by only seeing the anterior chamber depth through the Van Eyck technique or other technique, it doesn't reflect that the angles are open only. Just to get the whole status, the whole whole kind of parameters, you should perform gonioscopy. And the third one is, yes, gonioscopy is performed to accurately assess the angle status. Only through gonioscopy you should know like what is the angle, is it open or is it closed, any RPI is needed or not. So that's how through this case you need to understand, you need to remember angle intermittent headache can be caused by angle closure also. Okay. Yeah, so here I randomly put two images. So if you compare, if you see the image one and the image two, the main difference is, if you like see, the antechamber depth difference is there. The right eye is showing very like deep antechamber depth, whereas the image two, the left eye picture is showing very shallow antechamber depth. Okay. So here I'll tell you like what is the gonioscopy indication in case of low IOP and high IOP. So if the IOP is low, okay. So for first picture, if you get this type of anterior chamber depth and the IOP is low, or low means IOP is normal, okay, not raised, okay, IOP is normal, then you can skip gonioscopy for the patient as the IOP is also okay and the anterior chamber depth is this much, okay. But if you get if you get a normal IOP, but the anterior chamber depth is half CT, you have to do gonioscopy for the patient. Okay. Now for high IOP, anyway you need to perform gonioscopy, although it is it is half CT or one CT. Otherwise, you cannot understand what is the angle status. Okay. So for everything, for raised IOP, you need to do gonioscopy. For one CT or more than one CT, very deep AC, you can skip gonioscopy. For half CT, you have to perform gonioscopy, although the IOP comes normal. So from here, I would I request my panelist Arpita to take up this question. Like, how do you avoid IOP measurement error in patients with high astigmatism? Now over to you, Arpita.
So thank you for explaining the case number two and raising this question in the IP measurement error in patient with high astigmatism. So on GAT, you will see a red line marked on the side of the biprism. The red line is not for the IP measurement. It is only for the orientation. So this it's the red line is only for alignment in patient who is having high astigmatism. It's more than 3 diopter. So what you exactly do with the red line? So simply you have to rotate the prism so that the red line aligns with the axis of the minor cylinder and exactly 43-degree away from the steep axis. So while you are getting your steep axis at 90-degree, you have to move the red line of the prism. It's 90 plus 43, it's 333-degree. So this compares the elliptical shape of the cornea. So now the question is what happened with the astigmatism patient? In the astigmatism, the cornea has one steep meridian, which is having more curvature, and another one is flat meridian, which is having less curvature. So when you apply it, the area becomes oval, not circular. So it's give wrong IOP. And Goldman's biprism must treat both meridian equally to make the imprint round. So how 43-degree exactly fixes this? So the biprism has two halves that presses the cornea from two different directions. When you rotate the prism 43-degree from the steep axis, the biprism apex lines up halfway between the steep and flat meridian, but not exactly 45-degree because corneal astigmatism is not perfectly symmetric. The pressure is distributed such that way that part from the flattening force comes from the steep meridian and another part comes from the flat meridian. So at 43-degree area, the forces become from the both meridian becomes balanced. So basically, balanced forces equal to effective radius becomes the average of symmetric forces. So basically,
Arpita, you're not audible. Hello.
Looks like she's having connectivity issue, Anindita.
I think Arpita has a connectivity issue. I think.
Yeah. So can you call her and check once?
Sure.
Hello?
Yes, you're audible.
Should I repeat it again?
Yes, please, I think so.
Not completely. From where you left, you can continue, I think.
Okay, so why we are talking about only 43-degree axis? So now I can explain that the bifield. My voice is clear?
Yes, you can continue, Arpita.
So the biprism has two halves that presses the cornea from two different directions. When you rotate the biprism 43-degree from the steep axis, the biprism apex lines up halfway between the steep and flat meridian, but not exactly 45-degree because corneal astigmatism is not perfectly symmetric. The pressure is distributed such that way the part from the flattening port comes from the steep meridian and another part comes from the flat meridian. At 43-degree area, the forces become in from both meridian becomes balanced. So basically, balanced forces equal to effective radius becomes the average of steep and flat. Basically, biprism optically averages the steep and flat meridian, and this optical effect makes the oval applanation area behaving like a circle. So in these cases, like keratoconus, CMCD, or any astigmatism cornea, we have to rotate the red line from the steep axis, what we exactly got. So is it clear or anything, Anindita?
Yes, it's clear, but I have a small doubt. Like, if you do not rotate the probe, respective of the axis of the cylinder, like how the IOP will vary? Like, it will give a false high IOP or a false low IOP? That's one of my questions.
So to encountering you that if you don't rotate the red line 43-degree from the steep axis, you will definitely get falsely high IOP. Because already I explained that why does the IOP become high? In astigmatic cornea, the steep axis has more curvature, more resistance to flattening over than the flat axis. So it needs more force to applanate. So if you leave the red line without align with the steep axis from the 43-degree, you are applanting more along the steep curvature so that the Goldman applanation tonometry needs more force to achieve the endpoint. So basically more force equal to the instrument source higher IOP. So without rotating, steep meridian dominates over the flat meridian and IOP will be overestimated. So I hope I made it clear with these two questions.
Yeah, fine. Thanks.
So will you please.
So,
So I have two questions for Anindita for you. Am I audible?
yes, you're on.
So is there any
Hello. So the next question will be how we will ensure the patient's safety after tonometry. Yes, although we do day-to-day basis like tonometry, we do daily basis. So in many patients we do. So always you need to take care. We need to be careful like how we'll maintain the patient safety. Yeah. So first you have to maintain a septic precaution. So that means you always clean and disinfect the tonometer tip immediately with you can use 70% isopropyl alcohol. That's the alcohol swab we use in our clinic also, just to disinfect and clean the probe. Okay, and after cleaning the probe, you should not take the IOP immediately because it can happen. It can causes corneal toxicity if you take IOP. So you need to allow the biprism for air drying and completely before the next use. So this is the first one, and the second is you need to look for corneal integrity. Okay, so after doing applanation tonometry, you need to quickly check, is there any abrasion or any epithelial defect is there. You can ask the patient also that are they having any foreign body sensation or any pain, any fluttering issue. So if they are complaining, if they are not comfortable, like very much they are symptomatic, then you can instill 1 drop of lubricants also after the tonometry to them. Okay. Next is you should advise the patient not to rub their eyes, because as we instill anesthesia drop, so that effect will stay for 10 to 15 minutes. So if they do rubbing their eyes, they don't understand the pain while rubbing, and if they do rigorous rubbing, then it will causes abrasion, or again the epidefect can be there. Okay, so you should advise the patient not to rub their eyes until the anesthesia goes up. At least for 10 to 15 minutes should not touch their eyes. Okay, just like you have to inform the patient. Okay, and one more is you need to confirm the patients that the tonometry tip is not cracked before using the tonometry tip. Okay, otherwise it can it can harm your cornea. Okay, and next, the most thing is you need to ensure the proper calibration of the tonometry. So whatever the reading you get, that will be the safe and accurate for the patient. And for and after the tonometry procedure, you need to note down you need to do proper documentation. How you do the documentation? You need to write the IOP with the intraocular pressure, with the timing it was taken, and the time when it was taken. So always you need to mention at because of the diagonal factor, the IOP also can be changed over the time. Okay, so always you need to mention the time along with the IOP, and the unit also you need to take. You need to write. Okay, so those are the things you need to ensure for patient safety after tonometry.
So thank you very much for explaining the post-instrument care, the special care after tonometry, or while doing the tonometry. Now the second question is
Arpita,
the
one
when
sec. Before going to second question, can you guys, when you're talking, turn on your cameras, okay? And mainly the Anindita, you also have to turn on the camera. Anindita, I have one question, follow-up question to you.
Yes, please.
Yeah, so when you were talking about the safety measures that we need to ensure during tonometry, you said before measuring, we need how to disinfect the tonometer
Mhm.
uh, by prism. So what about after performing? What is the procedure of cleaning the tonometry by prism? Did
Mainly
you already mentioned it? Did I miss it or?
before and after, you need to
Okay,
with the biprism, I mean with the alcohol swab. Otherwise, how will clean and disinfect? We don't know, na? Like is it cleaned or not? So we need to clean after the procedure immediately. The biprism.
okay. So you use alcohol swabs only
Using
in
alcohol
the
swab.
clinic.
We use alcohol swab, that is 70% isopropyl alcohol we use.
Okay, good. Fine. You can proceed to next question. Arpita, you can start.
So I have another question regarding this that you already told about the gonioscopy procedure around. So how often we should do gonioscopy in a patient while we know that patient is diagnosed with glaucoma? Is it we should do in every follow-up visit, or it will take 6 months or 4 months gap? So what is the validation or any kind of gap you will need to do in a regular basis gonioscope?
Yeah.
Will you please elaborate on it?
Yeah, it's a nice question. See, as per AAO guideline, I mean American Academy of Ophthalmology guideline, we need to perform the gonioscopy for a follow-up case every 1 to 5 years. Okay, but yes, that's okay. But it actually vary patient to patient. Okay, you need to look upon many factors while repeating or while on doing a follow-up case. Okay, so the first one is if you get any new symptoms, just like pain or headache. Okay, pain and headache complaint matters a lot. Just like I explained in the case also, I presented one case that intermittent headache patient came. Okay, so those type of cases also you can the gonioscopy can be done. Okay, And this glaucoma is a progressive disease. Okay, so if when after giving a maximum treatment, when the patient was treated with maximum anti-glaucoma medications and everything is giving, but still the IOP is showing raised, or the IOP is not coming under control. Okay, that time and the patient before, maybe the patient was diagnosed with open angle glaucoma, and in between we never done the gonioscopy, and that time we can missed the mixed astigmatism factor. Okay, so what is a mixed astigmatism? Sometimes the open angle glaucoma patient can be turned to the angle closer. Okay, that can be happen. So we need to check this one. If we get the progressive disease is not under not control, or with the medicine or with the maximum treatment. Okay, and next is if we get any new findings. Suppose the anterior chamber depth was 1 cm, I mean a normal or deep 1 cm is there. Okay, suppose because of the any cataract is change, not because of cataract, be any because suppose the anterior chamber depth becomes shallow. Okay, so that time you need to repeat gonioscopy. Why it is? One more thing, if that is because of the cataractous change, it will happen unilaterally. So bilateral, if it is in the both the eyes, the bilateral happening will be the bilateral happen will be for glaucoma case. So if this is cataractous, then that is okay, that is fine. The anterior chamber depth will be shallow. Okay, but if it is bilateral, then the patient was again suggested for advice for LVPEI, peripheral iridotomy. Okay, and that's all. Like. And if you get any new if you see any pseudo exfoliation, although pseudo exfoliation is not a sudden, you will see certain, like sudden you cannot see the previously also it will be there, but suppose the patient is coming after long follow-up. Okay, that time also we need to repeat them. So that's how it depends from patient to patient, the gonioscopy actually.
Anindita, I have one question. Maybe it would be interest of audience. Can you also explain how do you ensure safety while doing a gonioscopy?
Yeah, nice. So the gonioscopy always see. Again, will we need to use the alcohol swab for the just to clean or disinfect the gonioscopy. Okay, but before doing gonioscopy, you should check the corneal status. Is it okay or not? Okay, if it is if it is there is no epithelial defect or no speakers, nothing happened in the cornea, then only you can perform gonioscopy. And after doing gonioscopy, you can use alcohol swab, or you can directly wash into water also. You directly wash with water also the gonioscopy lenses before using in the other patient. Okay, and that's all. And if the patient is uncomfortable, you can instill lubricant. Just it is just same, like although because it is also the same procedure, like we are putting on the over the cornea, right? So that's how we need to disinfect it, and if possible with the alcohol swab, and if not, then you can wash with water also, no issue. The gonioscope lens.
So you use topical anesthesia?
Yeah, that's all. Before doing the just like before doing the tonometry, we instill parakin. I mean anesthesia. Through parakin we instill. That's how the gonioscopy. Before gonioscopy also we use parakin just to for the topical anesthesia. Otherwise, patient will not be cooperative to perform this test.
Yeah, because the both are, kind of it is invasive techniques, right? So sometimes the patients may feel anxious. Okay, they might be anxious when you're taking the instrument close to the eye.
Mm.
So how do you manage in that case? Did you encounter any patients like or children, particularly,
Yes,
you
in
know?
daily clinic, we actually, first of all, you need to explain the procedure properly to the patient. And for children, you can say like you can use the phrase like it's a camera. Okay, yeah, will capture your eyes, eye photo. That's all. Like they will cooperate nicely if you say it's a camera, because nowadays they are very photogenic. Okay, so you can say like it's a camera. That's how I used to manage my child patient. Like it's a camera, it will not harm you. But for any adult patient, you need to properly elaborate the procedure, like, and why you are doing so, and what will happen. It will not harm the cornea. It will just put the just place the lens or place the tonometry before tonometry place the tonometry, just to check and the status. They will cooperate. And you always need to mention the topical anesthesia thing also. They already will instill the anesthesia, so the patient will not feel anything. And although they, if any, in the meantime, the patient feels anything, they can inform us. That's how we need to do.
Can you also share your insights about, fixation? Are you giving fixation target when you're performing this both techniques, tonometry and gonioscopy? How do you, instruct patients?
Yes, nice point, because that is mandatory. If the patient doesn't fix it, we cannot do the gonioscopy and tonometry both. Okay, so you can ask the patient to check if the patient, if you're doing the right eye tonometry or gonioscopy, you can give the fixation to your right ear to fix it. Okay, so they can fix it directly to your right ear. Or else in the slit lamp we have a target in the light. You can give to like fixation line to fix it. And in the meantime, also you can ask the patient. Sometimes, mostly in the gonioscopy time, they don't fix it. They see here and there, okay, or sometimes because of the discomfortness or what, I don't know, but they see here and there. So that time also you just keep on telling them to see the fixation target, or else your ear, or that's all. They do can this too can you can like use as a target. I use in the clinic.
Okay, very good. So one more last follow-up question. So before you perform gonioscopy, do you check with ophthalmologist and based on their, suggestion, you will go ahead, or you will decide that where to perform and you will perform and then you will report it? How do you do in the practice?
Yeah, yeah. Always we need to take the like consent from a ophthalmologist before performing gonioscopy. Okay, because if after like if after doing everything, I mean till IOP, after doing the general workup till IOP, next, like if the IOP is coming high, that just like gonioscopy indication I said, next we need to go and ask the consent. Is it okay to be done? Or if they say yes, then only we can do gonioscopy. We need to take the consent.
Yeah, very good. So as an optometrist, we should know when to go for gonioscopy. So that is very important. Okay, when you are assessing a patient, you should be knowing that the indication for the gonioscopy, and then you can interact with the ophthalmologist, and then you can proceed with performing gonioscopy. So taking consent from ophthalmologist is very crucial uh, part of it. Yes. Yeah, let us proceed with the next question, I think.
No, we don't have any question. There, it's the last one.
Okay, okay, fine. Any questions from Arpita? You want to discuss anything from? Fine. Can you throw your wisdom, or I would say, because you're experienced working in glaucoma OPDs. Uh, so about soft skills, like so when patient comes. And you need to perform certain investigations. So what is the procedure, that how do you approach to the patient? So you have already mentioned about history taking and things like that. As a professional, what all things we should make sure, when we are talking to patient or when you are doing particular procedure, mainly these kind of sensitive procedures, these are invasive procedures. Okay, what is the protocol that we need to follow, like standard operating protocols or ethical, clinical etiquettes?
See, till tonometry, I mean, history taking, visual acuity assessment, refraction, tonometry, slit lamp findings, until tonometry, it can be done easily by an optometrist. Okay. The next point is for ophthalmologist here. So if you know how to perform gonioscopy, you can take the consent from a doctor and perform it. And if the doctor feels reliable on your findings, then they will go with it, or else they will repeat it. And next, the step is fundoscopy. So they will do dilate the patient if needed. If not, then they will suggest for ERPI, just like primary angle closure. We see they suggest for the advice for ERPI, peripheral iridotomy. They do ERPI, and at the end, if the YECPA is also done, if the doctor feels if the Kuptik's ratio, like glaucomatous cupping is showing, then what we do here, we do Humphrey visual field test, because see, till there we just check the visual acuity, but no functional visual assessment is also, I mean, functional vision assessment is also needed for a glaucoma patient. Okay, just to check their visual field status. Okay, so here we do Humphrey visual field, and central corneal thickness is also sometimes needed for the patient. So first we need to explain to the patient like why it is important and what is the importance of this test, the investigation, OCT, RNFL OCT we do, just to see what is the RNFL loss, or what is the Kuptik's ratio in the measurement parameters, what are the other parameters we check, we do OCT. So first you need to explain to the patient why it is needed, what are the things, and always you need to say that, or always you have to say that what is the glaucoma progression, and how, like at the end stage of the glaucoma, what will happen and how it will loss. Suppose glaucoma, we all know it is like, first it will happen the peripheral visual field loss. Okay, the visual field loss will be there for peripheral, the central vision will be reserved till end. So the one patient can read till 20/20, but the visual field is only 10 degree left. It can happen easily. We see in glaucoma patient. Okay, so you have to make them understand what is the progression and what is the how you will go with it. Okay, so for a patient side, they need to understand those things. Okay, so that's how, if you explain properly to them, they will ready for any test or any investigations. That's how we deal with the patient in our glaucoma clinic.
Yeah, very good point that you have highlighted, that we need to explain to the patients that what we are going to do, what is the procedure that we are going to perform well before, and and also what is the need, why the importance of that clinical procedure to be explained to the patient. Okay, so that they are also not very anxious about what we are doing, and they establish the trust in you.
Yeah.
Okay, and sorry for that. Even if you look at the other aspects of it, as you rightly said, that they will have the peripheral vision loss, and then the patient mobility can get affected. Okay, so in the glaucoma OPD, whenever we are working, it's very important that the clinical etiquette starts from calling the patient from the waiting hall. Okay, so we have to, we know already patient is diagnosed with glaucoma, then we should definitely ensure that how we encounter patient, okay, how we hold the patient, and making sure that patient's mobility is okay, or he needs wheelchair, or how we need to encounter patient to the clinical room. Okay, so that need to be taken care, and whether the patient is accompanied with the attender or not. Okay, so we also need to check, and then we have to bring the attender, also give the and talk to them when you start calling the patient from the waiting hall. Interaction starts there, and then once you make them comfortable, they are really open to tell everything about their past history, and it'll be easy for us to elicit whatever the information that we need from that particular patient. Okay, so that is one thing that we need to highlight, I think. And also, any procedure that we are performing, we need to explain the procedure and how gently you are performing that procedure on that patient is important. Say for example, many a times we don't place this biprism back in place. Okay, after seeing a patient, we will just move that slit lamp on one side, and then you will proceed with the recording the examination findings. The later, when next patient comes, you will just open and put them on the slit lamp, and sometimes it's possible that can hurt, or it can be dangerous for patients. It can harm the patient, so we need to be really sensitive towards how what we are the skills that we are performing, and take care. That is one of the professionalism that we show towards the patient. Okay,
I think you
so
elicited a nice point that attenders, you should not take a glaucoma patient to your room without attender.
yeah,
Very much
exactly.
important.
Yeah, yeah. And counseling part is very, very
Yeah.
crucial as well. At the end, we need to explain the management part, or the treatment, or the prescription, whatever is prescribed by the ophthalmologist, explaining the dosage to the patient. Everything falls under clinical etiquette. So, how the concern that we show, and when patient comes back to the follow-up, if they miss out the any follow-ups, and explaining the patient the importance of the follow up, and how to adhere, or to be compliant with the instilling drops according to the prescription, and also noting down the last administration of the anti-glaucoma medication, which is also part of your history taking. So it's very important aspects that we need to take care as an optometrist. Anything else that I'm missing out, Anindita and Arpita?
Just wrapped everything.
It seems everything is covered.
Okay. No, no, I'm serious. See, you guys are, really working with patients,
Yes.
and
Yeah.
anything that comes to your mind related to soft skills that you can highlight right now. So we have a couple of minutes more. Otherwise, I think the cases were very good to understand. And you want to summarize those two cases, Nindita?
So yeah, it is. So the first case, like
Just
first.
overall, that what we learned from these two different cases.
From the first case, we learned how to take a history properly for a glaucoma patient. And the second is how you should assess the anterior chamber depth, because sometimes we do it, but again, some mistakes can happen in between, correct? So how will you carefully assess the anterior chamber depth? Third one is during tonometry, how you will adjust the probe nicely so that you can take the IOP properly. And the fourth, what are the things when the gonioscopy is needed? What are the indication of gonioscopy? In this case, we got raised IOP so that we did gonioscopy. So for the first case, those are the learning points. And the second case, the learning points is like we got a primary angle closure case. So the patient was complaining of intermittent headache. So that this case is saying the intermittent headache like can be caused by primary angle closure. Always we think of spectacle power change, or else migraine we think a lot of time, but primary angle closure also can causes intermittent headache. Okay, so and if you are getting close to borderline IOP, even 19 millimeter of mercury is the close to borderline 18, 19, you can, although the angle is showing 180 and you are getting the same type, the same kind of complaint, you can do gonioscopy for the patient, so that we cannot call for them another time, another visit. Just like we miss the gonioscopy, that's why we need to call them for follow-up. Okay, so this is the learning objective, like this is the second point. And although like gonioscopy, like peripheral anterior chamber depth is good to assess, but gonioscopy will get the will give you the whole status of the angles, that you should remember to your mind. Okay, so these are the learning objective from the second case. That's all from my side.
Yeah.
Yeah.
So it's so whatever the learning objectives or points that you are elaborating, Anindita. So I can see that it's very important to map the history taking or the chief complaint to the clinical findings. So in this second case, that's what we have seen. Patient's complaint should
Mm.
be taken. The chief complaint should be always kept in mind when you are examining the patient, and then map the history, whatever the details that you have elicited during history, and look at the findings and see that any test that we are missing out. Okay, and then making sure that we are giving best investigations and that leads to the diagnosis for
Yeah.
that patient, is it not?
Yes.
Very good. Yeah. So, Arpita, do you have any comments or take-home message to the audience?
So take-home methods means it's not literally history taking is basically the crucial part in only the glaucoma patient. You have to take history very meticulously from each and every patient. You have to know what is the chief complaint, what is the present illness, whatever the patient is following or facing now. So not only glaucoma history, it's applicable in every type of patient. Like patient is coming with the ulcer, any kind of infection, headache, anything. So you have to be more cautious when you are taking history and the other all of the exam examination while you are doing refraction and all. For the baseline, as optometrists, we should do this works in for honesty that we are taking this kind of thing in a general way. So after taking the history, then the some couple of question will come. Relating the whatever the patient will answer, so that the first thing indicates your thought process of diagnosis and all. So that's all about our case one and two.
Okay.
From my
Thank you so much. Yeah, Arpita and Anindita, do you have anything?
like one take-home message we can
Yeah,
get, like we can bring from this like PPT, like history can reveal half of the diagnosis and the treatment, not only for glaucoma, for anything. So you should always be careful
very true. Very
in
true.
history.
Yes, yes, exactly. Thank you. Thank you so much, both of you. It's a wonderful session. And I would like to end this session here. Thank you, DocMode, for being with us and supporting us. Thank you so
Ruby.
much. Yeah.
Thank you, Ruby. Thank you,